I'm going to be talking about spinal cord stimulation, essentially for failed back surgery syndrome. But just to sort of reiterate, atypical facial pain is kind of a pet project of mine because there are a lot of people out there with atypical facial pain, not trigeminal neuralgia, and there's very limited options for them. And we have had quite good success with subcutaneous stimulation, either in the supraorbital region or infraorbital region. For V3 type pain, I haven't really figured out a good way to keep a lead from migrating, but just as an aside, I think it's a great alternative for people that you really don't have any good options for. So let me just kind of pick up where Dr. David left off. As a disclosure, I have been a consultant for essentially all of the companies at one point or another, either helping with lead design, trial design, or just doing roundtables and teaching. So the trial has been successful, and again, we talk about 50% pain relief during the trial as being successful. That's sort of the number, but as he said before, you really want to find out if there's any functional improvement. I really want to hear that they're able to stand straighter, they're able to walk a lot farther, they're outside doing gardening, which they haven't done in years. I mean, usually it's pretty obvious. They'll volunteer it. The people who are really good trial candidates, permanent candidates, they're pretty easy to pick out. The hard guys are the ones that are, oh yeah, I kind of had 50% pain relief, and you have to kind of say, okay, did you have any improvements? And they're like, well, maybe, I took a little less medication. Those people, I always actually say, okay, I'm worried that you might not do well with a permanent stimulator. I do think that generally there is a placebo effect with the trial. Everybody really wants it to work. So I tell people, look, this is likely to not be as good as it was during the trial. So I want to see a 70% pain reduction and significant functional improvement to really go forward with a permanent implant, which is quite costly, risky, and they got to have the device for the rest of their life, essentially. And so I always make sure, that they're okay with this. When we put it in, we're not planning to take it out. Yes, we technically can, but they have to be okay with the idea of this foreign body in them for the rest of their lives, or else we really shouldn't go forward with this. Then you also have to talk about, well, what kind of permanent implant are we going to do? Is it going to be rechargeable? Is it going to be single cell? I'd say more than 90%, I believe, implants, at least in this Northwest region, are rechargeable batteries, not single cell. But there are areas where single cells are very popular, and for certain patients it might be the right thing. And then you have to talk about whether you're going to use a percutaneous approach or a paddle lead. I'm a neurosurgeon, so I'm very kind of biased towards the paddle lead. I'll make no bones about it, and we'll talk a little bit about why that is. And then you also have to talk about where you're going to place it, the battery in particular, because there's no perfect place in the body where 100% of patients are going to be fine with it there. So you really have to kind of look at their body habitus, talk about what kind of sleep patterns they have, and just their overall preferences in picking a location. So first, to talk about percutaneous versus surgical paddle leads. Here you can see just an example of each of them, and it's pretty easy to just see right here that the perc leads these days have a better rostrocaudal access than the paddle leads do, and the paddle leads essentially have a better left-right access to the spinal canal, and I think that's a very important thing to remember as you're picking this. Somebody asked, is there any trial looking at perc versus paddle? And there has been one trial. It was a long time ago, back in 2002, with Richard North. He's a neurosurgeon at Hopkins, and he basically does both perc and paddle permanent implants, and he randomized 24 patients after the trial was done, to either do a perc implant or paddle lead implant. Unfortunately, this was back when they were both essentially 4 contacts. So it was either a 4-contact perc or a 4-contact paddle. And so the results are a little bit old now to be interpreting well, but essentially he did find that the paddle leads had a better low back coverage and low back pain relief than the percutaneous leads did, but that was not sustained in terms of the pain relief for more than about 6 months. At 1 year, it was not significant between the two. But the only technical things that he really did definitively say with this study was that when patients rated how much area coverage they had in terms of their painful areas, you can see here the 67% with the insulated paddle lead and 47% with the percutaneous leads. So there's definitely a better coverage with the paddle leads. But then when you went down and had them draw out their areas on a piece of paper of where their pain was versus where the coverage was, and then you actually looked at the area, it was still better with the paddle lead than the perc lead, but it wasn't significant. So not a super strong difference. But the one clear difference was that the voltage was about half for the paddle lead than it was for the perc lead. And that was, we'll talk a little bit about why that might be. I think that one of the main advantages of the paddle lead is that it directs all the energy essentially down ventrally into the dorsal columns as opposed to radially, because there's no insulation on the dorsal aspect of the lead for a percutaneous lead. So it is more efficient that way. You're also bringing the paddle lead takes more space, so the electrodes are actually approaching the dorsal columns a little closer because you're obliterating some of that CSF space because of the size of the electrode. It also has, I believe, a better apposition to the dura. In other words, once it's scarred into place, it's really the migration issue for me. There's really no left-right. I've had one paddle lead, I think, out of, about 500 where it looks like within the first 24 hours it moved a little bit to the right in that patient. But other than that, they're very, very good at staying still compared to the perc leads. And as Dr. Naidoo is saying, that the implant techniques, I think, are getting better and better for both perc and paddle lead. So I'm not sure, whether migration is going to be as much of an issue going down the line, but certainly historically, the number of revisions that have happened across the industry has been one of the problems in, sustaining this as a therapy from the insurance perspective. And we need to do everything possible as a, pain community to try to decrease the number of revisions that have to take place. And I think most people do agree that the paddle leads are less likely to require a revision due to migration than the perc leads. Disadvantages, obviously, are that it is a spine surgery. You have to generally do a little laminotomy to place the electrode, so there is more risk to the cord and perhaps more recovery time. And if you have to take it out, it is more difficult to do that. Here's an example of the different kind of current generation paddle leads from the different companies. All of them have, 2 or more columns, and they have different rostrocaudal access. Basically, there's either a 4-column or 5-column lead design between Boston Scientific and St. Jude. St. Jude has a 5-column, but the outside columns are actually not independent contacts. 2 of the contacts are in series with each other, so they're not perfectly independently controllable on the outside columns. Boston Scientific has independently controllable contacts on all 4 columns, and Medtronic has a 3-column paddle. Dr. David already went over the perc. There's perc leads. There's a wide variety of different percutaneous electrodes that can be placed permanently. Essentially, most, I think, patients get a 2-column or a 2-lead implant for percutaneous leads, and generally you can either have 8 contacts or up to 16 contacts with Boston for each lead. So this is my kind of comparison slide. Dr. Naidoo also had a similar one, and this is what I've believe is kind of important factors to think about when you're choosing a permanent stimulator. Most of the time the choice has already been made for me because somebody's done a trial and picked a system, and I just go with the system that they trialed with. But there are differences. There's now 4 companies out there. There basically is either 16 or 32 contacts with the different systems. You're talking about either independent amplifiers or not independent amplifiers, and We can go over that more in the lab if people want, but it's basically the ability to turn on individual contacts independently to others. So with Boston, you can turn on one cathode and give it 42% of the cathodal current and give 58% to another cathode, and so it allows you to independently control each of the cathodes during the stimulation. The other companies, when you turn on the cathodes, it's basically all the cathodic current is delivered to all of the contacts at the same time, and so how much current goes through each contact is dependent upon the resistance of that cathode in relation to the other anodes that are around. So you don't quite have the ability to independently say, okay, I want this much current to go to this contact in the lead. Medtronic is the only one that has positional compensation to be able to basically switch programs depending upon whether you're lying down or sitting up to help decrease positional stimulation, which can be an issue for some patients. St. Jude has the longest device warranty. All of the companies now have high-frequency stimulation, as in either 1,000 or higher. Nevro is the only one that has this proprietary ultra-high frequency 10,000 hertz stimulation, although I believe Boston Scientific is also doing a trial right now looking at 10,000 hertz, but I don't think it's available clinically. And then A&S St. Jude also has this burst technology, which is actually not yet approved to my knowledge in the US, but it is being used in Europe. And then the MRI compatibility really is a big issue. All of the companies are working on this very actively. I would say Medtronic is out ahead of the other companies in terms of having full body MRI conditional compatibility. Unfortunately, it's only with the percutaneous leads. They don't have a paddle lead that is fully MRI compatible. But all of the companies basically have a brain compatibility, or can. Not all the you can't use any equipment with any company and get brain compatibility, but all the companies have the ability to have an implant that is compatible with brain MRI. And to my feeling, that is the most important compatibility to have. Is if somebody has a, God forbid, a brain tumor or something, they really do need an MRI in that situation. So I'm going to talk a little bit about kind of the differences in the paddle leads and differences in programming, highlighting Boston Scientific, not necessarily because they're sponsoring this, but more because I just like their technology in this respect. They are the only company that has a 32 contact pulse generator and paddle lead, and when you combine that with the independent current control at each of the contacts, what it translates to is a much more robust and defined ability to shape the current that you're trying to push into the dorsal columns. So all of them, have the ability to, as you can kind of see on the right side, the blue areas are the sort of independent areas where you can place that current, that cathodal stimulating current. But the more contacts you have and the more independently you can control each of those contacts, the higher number of possible places you can put that field of stimulation, essentially. And then there's also, Boston has this what's called Illumina 3D, and to me it's one of the reasons why I believe that the paddle leads are better than the percutaneous leads, mostly in terms of having the number of columns that you can have access to on a left to right differentiation. They've created this programming algorithm where you no longer have to talk about which contacts you're turning on and off. You essentially say where you want the stimulation to go, and then it will choose through its algorithm which cathodes and which anodes to provide to get the stimulation into that area. And in particular, one of the most difficult things with spinal cord stimulation is to get really good left to right flexibility in terms of covering. Oftentimes you want to be more lateral for hip, more medial for back, and to have that flexibility, you really want to have good left-right coverage with your electrodes. And then this allows with this Illumina 3D, you can actually push that current even farther to the side by intensifying anodes on one side to kind of push that current more laterally or medially. And as Dr. David had alluded to, with the tripole configuration, we can actually try to suppress the stimulation out in the dorsal roots, where stimulation is generally not very pleasant, by providing anodes on each side of the cathode that suppresses the lateral stimulation. And when you can get an anode on each side and press that cathodal current more medially, you can get it deeper and hopefully get more back fibers in the process. So having a construct in the patient where you have the ability to have an anode on either side of the cathode, I believe, is a very helpful thing, and you really need at least 3 columns to be able to do that. And so the paddle lead is a little bit better, or in terms of achieving that, unless you're going to do a tripole configuration with the perc lead, which is certainly possible. So when you're thinking about doing the permanent implant, positioning is very important. I always have patients prone on laminectomy rolls, arms forward. I have patients awake, at least for part of it. Generally, I have them asleep in the beginning for, numbing up the skin, doing the dissection, wake them up once the electrode's in place, do the mapping of the paresthesia, make sure we can get it where they want it, and then make them more sleepy again. Essentially, propofol is pretty much all we use. Dexamethasone we've used in the past, but I've just found that propofol is so much faster to get from deep to awake and from awake to deep. It really, really works well. And essentially, we can talk about it more in the lab, but we generally want to go for the paddle lead. We want to go about one level below where you want the paddle lead to be placed, and we do the laminotomy there. I generally use a small retractor set, which we can go over in the lab as well if you guys want to practice doing the paddle leads. And here you can see generally I want to do a hemilaminotomy, meaning just take the lamina down on one side. I try to leave the spinous process intact, interspinous ligaments intact, and then just find the epidural space and slide the electrode in rostrally. And here's just an example of a cover edge paddle lead placed intraoperatively. I'm not really going to go too much into the percutaneous lead placement. We'll have a chance to kind of go over that in the lab, and Dr. David kind of went through most of the technique anyway, but just to let you know that the 16 contact percutaneous leads do have that extended rostrocaudal coverage. In terms of IPG location, I essentially have 2 places that we put it. One is in the low back. Basically try to put it in the small of the back where it will be, in that curvature and hopefully not where somebody's going to lay on it. And most of them I'm doing this way today. The other place is really in the buttocks, just below the belt line. Try to place the IPG. I think for some people it works very well, but particularly people with a lot of adipose tissue, there's more room for it to kind of swim around in the buttocks than there is in the low back. There's a much more, I think, uniform thickness to the skin in the low back than there is in the buttocks, and generally we want to find that plane between the fascia and the adipose to place the battery if we can, because it tends to sit more still in that location. So now I just want to go into a couple of the, two of the trials that I think are the most important for spinal cord stimulation. Dr. Naidoo already talked about, I think touched on these, but I want to go into a little bit more detail. First one was, again, by Richard North at Hopkins. He did this in 2005. He essentially randomized patients who had already had surgery but failed surgery, continued to have pain, either to repeat surgery again or to spinal cord stimulation. And what's interesting about this study is that all these patients had to had to be good surgical candidates. So they had to have lesions still that he thought he could improve with surgery. So it's not that they were, the stimulator patients were only the ones where he didn't think he could do surgery to benefit them. These were patients where he might have still seen pathology in the spine and randomized them to either reoperation or spinal cord stimulation. And you can see basically after 6 months, patients could cross over from one category to the other. And you can see in the crossover design, I don't know if we have our pointer working here. You can see that 14 patients crossed over from the reoperation to the spinal cord stimulation. 5 patients crossed over from spinal cord stimulation to reoperation. But in the end, basically 2 years down the line, we had 15 successes with spinal cord stimulation and 3 successes with reoperation. So the success rate was about 47%. And again, the success rate means that there's 50% or better control of their leg pain. And still, 47% is not as great as I'd like to see it at 2 years. But again, this was done with that same technology with 4 contacts back in 2005. I think we're doing better today. But very, poor 12% success rate with reoperation. And the people that switched over basically did just almost as well as the patients who were initially randomized to spinal cord stimulation. They also, in another study, looked at the cost associated with these patients and essentially found that, both were very expensive options, essentially, whether to reoperate or to provide spinal cord stimulation. But spinal cord stimulation, A, was more successful, and B, was cheaper than reoperation. So I believe that, this really is good data to, talk to about with your patients when they come and they are trying to figure out whether they should go back for surgery or whether they should pursue spinal cord stimulation. I think it's a very, very viable option for patients. The other big study was the process study. This was, again, done by Dr. Kumar and others. It was a European and North American study. There were 100 patients that were randomized either to continue with their best medical management or to undergo spinal cord stimulation. It was similar in that it could have a 6-month crossover from one to the other. By the end of the 2 years, many of the patients in the conservative medical management had switched over to spinal cord stimulation in the end. And clearly, both at 6 months and at 2 years, the group that had spinal cord stimulation did better than the group with best medical management. This is just the scores for the spinal cord stimulation group, which I think is interesting to go through. Again, this is with the older technology, 4-contact electrodes. You can see here that the most significant finding was that the leg pain was still significantly diminished at 2 years compared to baseline. In this study, back pain initially had gotten better, but kind of drifted up to the point where it was no longer significantly improved 2 years later in the process study. The disability was significantly improved, and health-related quality of life was significantly improved at 2 years out. So pretty good results overall. As Dr. Naidoo also pointed out, this was a good study for looking at complications, and 31% of patients had a complication that required revision of some sort, which hopefully we really are doing a lot better today. And that some of the studies that have been done do show improvement, but 31 is a lot, and almost half of those were from lead migration and also from just loss of therapeutic effect and IPG migration is pretty low. So in the end, 100 patients randomized, primary outcome was 50% or better improvement in leg pain, significant improvement in the spinal cord stimulation group compared to the best medical management, which was sustained in the legs at 2 years out, but there was a pretty high revision rate. So now I just want to talk a little bit about a little more modern studies. These are probably not quite as good because not all of them are randomized and controlled. But Boston Scientific is in the process of following patients who have been implanted with their Spectra generator, which is their 32 contact pulse generator. They have 13 sites that they're following sequential patients, all sequential patients with. For this, it's called the Precision Retrospective Outcomes Registry, and they're looking at follow-up up to 2 years out. I think we're at 12 months now. I think at NANS they may be presenting 2 years. I'm not sure. Yeah, I think so. And so here I have just results from the trial as well as results from the permanent implant. You can see there are 13 sites that are involved. We are not one of them, but pretty representative across the U.S. other than the Northwest. Here you can see that the trial results show numeric rating scale for pain. Patients start at about a 7.5 during the trial, have a very significant drop down to 2.9, and then they independently looked at patients who they considered to have severe back pain. Those are basically 8 or higher. There was a very significant similar decrease in the pain during the trial. And this was also because it was using the 32 contact pulse generator. Most of these patients who had the trials done were using the 16 contact trial leads, so 2 16 contact leads. The permanent implant, now we have a 12-month outcome data, and you can see that the both in the all patient category and in the severe category, there's a sustained pain relief up to 12 months out, going from 8.75 in the severe group down to 3.0 in the numeric rating scale. And this is for overall pain, and then they also broke down back pain only. I think a lot of people have questions, how much better are we doing now in covering back pain than the process trial that we talked about back in 2005. And you can see here that there is a pretty good sustained back pain relief at 12 months out with this PRO data. Okay. So next I'm going to talk about 2 other studies, essentially highlighting 2 other technologies that are fairly new. One is Nevro. This is kind of just approved this year, but it's been under study for quite a few years now. This is a ultra high frequency stimulation, 10,000 hertz, and they are now on the market with an MRI conditional for head and extremity system. And I believe they have a 5-year warranty. So they've done 3 studies. One was a feasibility study in 2009. Then they followed up with a bigger study in Europe in 2013. And now they've just finished a study of 241 enrolled patients in 2015, I think just October of this year. And so with this Nevro, they call it Senza therapy. It's basically a percutaneous therapy. They don't have a paddle lead, which part of the therapy is part of the main advantage, they say, of the therapy is that there's no paresthesia, and so there's very little reason to have patients awake during the trial period, during the placement of the electrodes. But they do have fairly specific desire for placement of the electrodes. They basically want to have 2 leads that are staggered, and the idea is to have a double coverage of the lead over the T9-10 region, which they consider to be their kind of sweet spot for stimulation. And this is not necessarily the sweet spot for any kind of perceived paresthesia stimulation, but for the non-perceived stimulation, their previous studies showed that this was the best place for ideal coverage, pain coverage. So with this study, they had 198 patients that were randomized either to their high-frequency stimulation or to conventional spinal cord stimulation. And essentially, they had 90 implanted with the high frequency, 81 implanted with the traditional stimulation. And then their primary outcome was looking at back pain at 3 months, and then open label or a follow-up period at 12 months for the secondary analysis. They had more females than males, pretty similar though between the two different arms. Pretty significant history of back pain or of pain in general from 13 to 14 years. Pretty comparable groups overall though. You can see that the control group, we had 10,000 hertz in the high frequency group, and then the anywhere from 40 hertz to essentially 80, maybe up to 80 hertz for the conventional stimulation group. And the overall primary endpoint, which is 3 months out, looking at back pain relief, they found that with conventional therapy there was a 42% responder rate and 80.9% rate within their high frequency group. And so then looking at back pain VAS scores, you can see with the traditional stimulation, there was a significant decrease in back pain that was sustained out at 12 months. But with the Senza high-frequency stimulation, there was a improved back pain over the traditional stimulation.
What was the, can you get confirmation on what the other stimulator they were using was?
They actually used Boston Scientific was their comparison. Okay. They had essentially, I think they built their stimulator to kind of have the same electrode configuration as Boston. So,
how long, what time range, or what model of Boston Scientific?
Oh, I believe it was the old Precision. I'm not sure. Is that true? I don't. Yeah. The two main issues I have with the way, well, three main issues. One, I think they had the opportunity to do a truly placebo-controlled trial because there's no perception of the stimulation. So I think they really should have done, basically their therapy versus placebo, and it could have been totally blinded. They chose not to, I think mostly because they just wanted to get their product out on the market. And hopefully that will be done at some point because it really is a unique opportunity. The other is that, it isn't Boston's most current technology, which I do think was, a significant improvement with the 32 contact and with the paddle lead. The other thing is the paddle lead. I believe that I know that the center here in the Northwest that participated in this trial only used perc leads for the conventional stimulation. Again, I think people do better with paddle leads, and so it's hard to say how well this other group would have done if they had had paddle leads implanted rather than perc leads. So, it's not a perfect study, but not many studies are perfect in spinal cord stimulation.
Sorry, yeah. One question, I guess. What year was the model that they were comparing to? When did that one develop?
The Precision, the Boston Scientific, that was really 2004 was when their Precision came out. So I don't think did they change at all? So yeah, the 32 contact Spectra, which came out in 2013? 2012 was the first upgrade since 2004 for the pulse generator. Yeah.
I forget, was the Precision voltage or current?
Current regulated. Yeah. Okay. Yeah. All Boston has been current controlled since the beginning. Yeah. All right. So let's see. We have this is the leg pain. In addition to the back, their primary outcome was back, but they also looked at leg, and they did show an improvement that was superior to traditional stimulation at 12 months out in leg pain as well. So they're on the market now. They're just getting going. I have no clinical experience with it at all yet. So the other thing I just wanted to bring up was the burst technology that I believe Boston is studying also. But ANS St. Jude is really kind of pushing and is now available for them, and Europe is not yet available here. This was a study done by Dr. De Ritter in Belgium. He's really the guy that has pioneered burst therapy and works closely with St. Jude on it. He did a trial of 15 patients in Belgium. They have a fairly unique situation where they require patients to have 28-day trials. So they have to externalize leads for 28 days to be able to implant them. So he basically randomized 15 patients to have 1 week of either placebo stimulation, traditional tonic stimulation, which is kind of the standard perception paresthesia, and then 1 week of this burst therapy, which I'll talk about. But essentially, it's there's no perception with the burst therapy, and it combines both high frequency stimulation laid on top of a 40 hertz stimulation, and so this is the paradigm of the stimulation. Basically, you have 40 hertz of these intermittent burst stimuli, and then within each burst, which lasts for 10 milliseconds, you have a 500 hertz stimulation with very short pulse widths, and they argue that this is more physiologic because it more similarly mimics particularly what the thalamic cells of the brain are doing in terms of their frequency and bursting activity.
So what was the overall cycle frequency? Was that every second?
Well, it's basically 500 hertz within the burst, and then 40 hertz if you are counting between the bursts.
Okay, but each 500 burst interval was how long? Was it
10 milliseconds.
Okay, and then those 90 milliseconds of 40 hertz, or
90 milliseconds, but I don't think it was 90 milliseconds.
I don't know how frequently
Yeah.
that burst spike was.
Well, it's probably, I don't know, from what it looks like here, it's probably 15 milliseconds of nothing until you get the next burst at 500 hertz. So, And so this was their outcome in these 15 patients, pretty small sample size, but basically they found that, burst had the best overall effect compared to tonic stimulation or placebo, both for general pain, limb pain, and back pain as well. I like this study because it really did compare a placebo versus burst, neither of which were perceptible. So, assuming the patients didn't know whether they were getting burst or placebo, they really should have been able to, look at this question carefully. There was a perceptible stimulation week in between, but so I kind of discount this data if you're kind of looking at the, I like to just look at the placebo versus the burst. So I'm not aware of any bigger study that has looked at this, but I'm pretty sure they're working on one now. So overall, I think spinal cord stimulation is here to stay. It's a very, very viable, I think very good option for patients who have continued neuropathic pain, and even before surgery, as somebody mentioned. It's very rare that we do it before laminectomy or before a spine surgery, but certainly there have been patients who we've done it for, and I don't think there's any magic about whether it would work better after surgery than before surgery. I think it's just the way we think of treating back and leg pain is sort of surgery first, and certainly if there's a obvious pathology that I can see, and I think that it's correlates with their dermatomal pattern of their pain, I'm more likely to do surgery than spinal cord stimulation. But I would never just kind of discount spinal cord stimulation until surgery is done. Obviously, patients with complex regional pain syndrome, we're operating on before any kind of other surgery has been done as well. So hopefully we'll have a chance to kind of go over things in detail in the lab this afternoon. So thank you very much.